Assalamu alaikum. The long clinical consultation day. Mrs. Sophia, 34 years, with complaint of cough. Starting in a second. Okay, ready?
Okay.
Let's start.
Hello. My name is Dr. Abdullah. I'm one of the doctors at the clinic today. Can I confirm you are Ms. Sophia, 34 years old?
Yes, I am.
Can you tell me what brought you to our clinic today?
Yeah, doctor, I have cough for almost 1 month now.
Okay. Sorry to hear about that. Can you tell me this is the first time you have this cough?
Yeah, first time ever.
Okay. Can I ask you if it is worsening or it's getting better?
No, I
Over
feel it's
time?
not good. It's worse, doctor.
Worsening. I'm sorry to hear that. Okay. Can I ask you what seems to increase this cough? What do you
Whenever I
think?
do exercise, doctor, I feel the cough worse.
Okay. What do you think makes this cough better?
Yeah, when I get rest.
Okay. Do you feel that it's getting worse on a specific time of the day?
No, all the day.
Okay. Can I ask you if you have any shortness of breath?
Not usually, doctor, but yes, I notice also when I have this cough, I feel like short of breath.
Okay. Any noisy chest, any noisy sound in your chest?
No. Noisy breathing, no, doctor.
Noisy breathing. Is this cough with phlegm?
No.
There is blood with this, any blood with the cough?
No.
Okay. Can I ask you this difficulty breathing? Do you feel that you have difficulty breathing when you are lying flat on bed?
No, it's not related.
Okay. You told me after exercise, right? How much walking or how much exercise do you do before having this cough and this shortness of breath?
Yeah, when I do my daily activity at home, at the beginning, I feel a little bit okay, but after starting the daily activity, I feel the short of breath and cough comes.
Okay. And it does not come at night more than morning, you told me, right?
No.
The same. Okay. Any nasal discharge?
No.
Sinus pain?
No.
Any chest pain?
No.
Or leg swelling? Okay. Have you seen any doctor regarding this problem for the past month?
No, doctor. I went to my GP and he referred me to you.
Okay. Can I ask if you had any fever?
Yeah, doctor. I noticed that it's on and off since long time now, almost 2 months. But it's not that high, doctor. I measure it. It's like 38.
Okay, and first time you have this fever, right?
Yes.
Any weight changes you have?
I noticed my weight is not increased, doctor. But I can't say it's decreasing. So almost same. However, I'm eating well.
So you feel that your weight has decreased, right?
Yeah, I feel that, doctor.
This has been over the last 2 months or so?
Yeah.
Have you had any weather preferences?
No.
Any lumps or bumps in your body?
Yeah, doctor, I noticed there is some lumps under my armpit.
Anywhere else in your body? Any other lumps in your body other than the one under your armpits? In your neck, in your tummy?
Yeah, and the neck, doctor, I feel also some of them.
Okay. What about, sorry to ask you, in the private area? You feel any like
No, I
lumps?
didn't notice, doctor. I didn't
Do you
feel
have
it.
any? Okay. Do you have any night sweats?
Not so, doctor. I didn't notice.
Okay. Did you have any like joint pain or back pain?
Yeah, doctor, joint pain all over my body.
Okay. No specific site, right? No specific site for this
No.
joint pain. It's like generalized.
All
Okay. Can you tell me how much is the severity of this pain?
It's not that much, doctor. I can tolerate.
Over the scale of 1 to 10, how much do you think this pain is?
Like 5, doctor.
Okay. Can you describe it? Like, what's the character of this pain?
Dull aching.
And this one also started for the past 1 month?
Yeah, 2 months.
Okay. Any skin changes?
Yes, doctor.
Can you show me what are the skin changes you have?
Yeah, doctor. I noticed this rash in my legs.
Can you okay. Is it red and like, is it sorry, what's the color of this rash?
Yeah, doctor. It's a red one, but no discharge, doctor. It's red only.
Is it raised from the surface, from your skin surface?
Yeah, doctor. You're right.
Is it painful?
Yeah, doctor. This is the rash.
Okay. Is it painful?
Yeah, doctor. I feel it's painful.
Okay. Does it have any scales?
No.
Any oozing from this
No.
this rash? Any bleeding?
No.
This also has started over the past 1 or 2 months?
No, it's now 2 weeks.
2 weeks. I'm sorry to hear that.
It's on the screen. You can see it. Okay.
Yes, I can see it.
Okay.
Any hair changes?
No, doctor.
Any eye changes?
Yeah, some redness in my eyes.
Some redness? Any discharge from the eye?
No, only redness.
Any vision problem?
No. Apart from redness, no.
Okay. Any urine changes?
Water work, nothing, doctor.
Any bowel changes, like bowel habits or bowel problem, like increase?
Yeah, doctor. I feel some hard motion recently for the last 3 weeks.
Okay. And you told me the waterworks is okay. You don't feel that you need to go a lot to the, to urinate
Yeah. Yes, you're right, doctor. I feel more going frequently to the washroom.
And you feel more thirsty?
You're right, doctor.
Have you checked your blood sugar before?
Yeah, it's normal, doctor.
Have you had any headache?
Yes, I feel some headache and mood change.
This also has started. Sorry to ask you, this urine changes and the bowel habits. This started also for the past 1 or 2 months?
For the last 2 months, yes, doctor.
And the headache and the mood changes also?
Yes.
Okay. Any disturbance in your consciousness or concentration?
No,
Any like weakness or abnormal sensation in your body?
no,
Any problem with your walking?
no,
Okay. Can I think, okay. Any past history?
no, doctor. I am free.
Any family history?
Yes, doctor. My father was diabetic.
Okay. Can you show me your drug list?
Yes, I'm taking some non-steroidal for the pain, arthralgia, and paracetamol also if needed.
You have any allergies from any medications?
No, no.
What's your job, Mrs. Sophia?
My job?
Yes.
I'm teacher.
Okay. How much is this affecting your
Yeah,
job?
doctor. I feel too much tired now, and I'm not able to go to the work and to stand to teach.
I'm sorry to hear that. I'm going to refer you to the patient health therapist. Are you smoking?
No,
Are you drinking alcohol?
no.
Can I examine you?
Yes, sure.
Okay. Can I examine first the chest? Um, can I do an inspection first? There is any chest expansion limitation?
Not significant.
Okay. Any change in the percussion note?
Also not significant.
Can I auscultate the chest?
Yes, you can hear crackles, inspirator crackles.
Where exactly? Sorry.
Uh, Basal and mid zone.
Okay. Does it change with the cough?
No, doesn't change.
The character of this crackle is fine or coarse?
Fine.
Okay. Can I examine? Okay. Can I examine her respiratory rate and heart rate and blood pressure?
Yes, blood
And
pressure is normal. Heart rate is 55
mm,
and temperature 37.8.
um, okay. Can I examine the eyes?
Yes, no redness now. It's intact. Both are
Okay.
intact.
Can I examine the mouth? Any changes?
No ulcers, no cyanosis.
Okay. Can I examine the GVP?
Not raised GVP, normal.
Uh, can I examine her lower limbs? Any
Yeah,
edema?
yes, you notice the rash, the redness and some hotness,
Okay.
tender on palpation
Mm.
and large in this size of this redness, but no oozing, no
Okay.
ulcer.
And no edema, right? No edema?
No, just around the rash.
Okay. Can I examine the lymph node, cervical area?
Yeah, you can feel it's not tender, lymphadenopathy, cervical and axillary.
Okay. Can I examine the abdomen also if there is any liver or spleen changes?
And no no splenomegaly,
And the kidneys are no pollutants?
no palatable kidneys.
Okay. What's your concern?
Let's, yeah.
Okay.
What I have, doctor, why why I have this cough for the last 1 month? It's something alarming.
So I think that you have, after examining you and taking full history from you, I think that you have something called sarcoidosis. This is like a disease of unknown cause. We don't know the cause of this disease that has affected your lungs and uh, caused these lumps in your body, and also have caused this rash and eye changes, and also the urine changes. Any other concerns, Mrs. Sophia?
Yeah, doctor, why I'm going frequently to the washroom and feeling thirsty. Is it diabetes, like my father?
Actually, now I would like to check your random blood sugar, and to make sure that your random sugar is okay. But also sarcoidosis, this disease, don't mind the medical name, also can lead to increase in some salt in your body called calcium that can lead to your symptom of going frequently to the washroom. But we have to run also more lab tests to make sure about that. Any other concern, Ms. Sophia?
No, doctor, thank you.
Thank you so much.
Okay, time's up almost. Can you present your case?
So after taking history and full examination of Mrs. Sophia, I think that she has sarcoidosis. This is the evidence evidenced by the history of the chest symptoms of shortness of breath and recurrent cough, also, plus the systemic manifestations of on and off fever, also with the generalized lymphadenopathy in her body, also with the symptoms of arthralgia, and also the eye changes, the polyuria and polydipsia, and also the bowel changes, which indicate there's the presence of hypercalcemia, and also the headache with the mood changes. So all of these systemic manifestations can go with the diagnosis of sarcoidosis.
What are the differential diagnoses? Think. Yeah.
Could be what
cough in young female. What do you think? Just imagine in young female having
could
cough.
Could be other rheumatological diseases like for example, I'm not sure, systemic lupus, for example.
Okay, what can systemic lupus lead to?
Systemic lupus is affecting also multiple systems. It can affect.
Okay. So how it can cause cough?
Lupus pneumonitis. Lupus pneumonitis. It can cause lupus pneumonitis. One of the
can't cause interstitial pulmonary or interstitial lung disease.
Yeah, it's more.
So I'm talking about dry cough in young female. Always put the differential for the complaint. What else in young female? Dry cough. Do you think asthma?
Yeah, dry cough can, but she does not have any noisy chest. But can be.
You can say, but you can say against that. But
against
still, yeah. But still, it's dry cough as a presentation, right?
Yes, that's right.
Yeah. Okay. Okay, give me one more. If I will give you.
It can be, but we should ask her, I think, about the bats and the birds and but I'm not sure. This is young, it will not make a difference between young and old,
Okay, that's enough. That's enough. At least give two common cause or two common differential for dry cough. Asthma, one of them. Interstitial pulmonary. Interstitial lung disease and idiopathic pulmonary fibrosis. You can put it. It's dry cough with not cleared by cough. I mean the crackle itself. So you can put both. Anyway, how to investigate this patient?
So apart from basic investigation, like kidney function test, liver function test, CBC, I would like to do inflammatory markers like CRP.
Okay.
Also, I would like to do chest X-ray and
Okay, before going to the image, try to finish the lab.
أيوة, sorry. I jumped to that. Sorry.
Okay, so
I was thinking about the يعني
yes, I
going
know, specific for the
yeah.
sarcoidosis, but what lab you can find abnormal in this patient?
So we will also do corrected calcium in the
Excellent. Yes, this is
and
this is brilliant. Yes, what else?
the ACE.
Excellent. Yes,
Yes, the ACE.
angiotensin converting enzyme, right?
Yes.
Try
Yes.
not to mention abbreviation or to mention and explain.
Yes.
Okay, ACE level, okay, angiotensin converting enzyme, okay. What else? Will you do a bone profile?
Yeah,
Like,
because
calcium,
yes, we
vitamin
have to
D,
do right.
phosphorus.
Full profile, yes, calcium,
Yes,
vitamin D,
okay,
phosphorus, and PTH. Yes.
okay. And now go to the image. What image you start with?
First of all, we will do chest X-ray,
Excellent.
and we we will need to do a high resolution CT for
Excellent.
the interstitial affection,
Mhm.
and for the lymph nodes, to also diagnose the mediastinal lymph nodes, and
Okay. This is by image. What if you suggest to do invasive procedure? What procedure you will do?
we will do lymph node biopsy, and
Okay.
lymph node
Either
biopsy.
or
Uh, uh,
from where, I mean, to
we can do from the mediastinal lymph nodes, or we can do
excellent.
from the axillary. But it's better from the mediastinal. Yeah.
It's okay.
The peripheral, yes, can be.
Yeah.
The more diagnostic is the one in the mediastinal region. Could be.
Okay. Yeah. Then the yes, you mentioned the investigation for complication like ACE. Okay. Now give me the management plan.
So first of all, non-pharmacological patient education, patient counseling, and referral to multidisciplinary team from the pulmonologist and the rheumatologist and the immunologist. يعني sarcoidosis, I think in the beginning it does not.
It's multi-system. So yeah, multidisciplinary team, ophthalmologist, dermatology.
Yes.
Yes, and also nephrology for hypercalcemia. Yes. Okay. Radiology intervention. You can find a lot of teams. Okay. Yes, the pharmacological.
Pharmacological, I think nothing in the يعني sarcoidosis is supposed to be self-limited disease, except if there is organ failure, we have to go for pulse steroids.
If give me indication for the steroid in sarcoidosis. There is 3 in indication.
I think the CNS and
excellent. Yes, neurosarcoidosis. What else?
And I'm not sure kidney or not. CNS. This is the one I'm sure about.
Okay. CNS. Okay, there is the staging. You remember the staging for sarcoidosis in the lungs?
Now, no, actually, sorry.
Okay,
I can't remember.
Let's start from 0. Normal chest, right?
Yes.
No finding. Then stage 1. You'll not find any fibrosis.
Okay.
Just lymphadenopathy bilaterally. Then this is stage 1. Stage 2, you will find both.
Okay.
Plus infiltrate. Then the stage 3 you will have the infiltrates alone, and the stage 4 you will find fibrosis. F4 fibrosis.
Okay.
Okay. So the advanced stage you will start steroid.
Okay.
What else? There is also one indication, which is called
Um, cardiac,
Lofgren, Lofgren,
love, I cannot
Lofgren
remember.
syndrome. Yes, fever, lymphadenopathy, and
Okay, okay. Um,
arthritis. Arthritis.
okay, okay, okay.
Okay, yeah.
Yes.
Let's go to the biopsy. What result or what's
Uh,
the histopathology or the finding in the biopsy?
non-caseating granulomas.
Excellent. Okay, the last question. Yeah, we didn't investigate for complication for
Yes,
the heart
yes,
complication.
Mm.
What you might find and what to do.
Um, I think it can cause some. And we have to do ECG and we have to do
Okay,
echocardiogram.
you might find,
Uh, heart block. I think
yes, okay.
heart block. Heart block.
And the echo might show.
Um,
So remember, sarcoidosis is infiltrative, right? It's infiltrative.
cardiomegaly.
Cardiomyopathy. What's kind of
Cardiomyopathy.
cardiomyopathy? What?
Yes. Restrictive. Cardiomyopathy.
Yeah, restrictive cardiomyopathy.
Restrictive.
Yes.
Yes. Yes. Restrictive cardiomyopathy.
Okay. Yes, I think we are done with this topic. 10 minutes questions.
Mm.
Just because, also someone mentioned this pulmonary function test. Yeah, thank you.
Yes.
It will be,
It will be a restrictive pattern with
okay.
forced expiratory volume 1 over
Yeah,
forced vital capacity less than more than 70%.
excellent.
With
And
Tilco
yeah,
will be
Delco will be,
reduced.
yes, exactly. Okay, I think this is the case. You catch it from erythema nodosum, I guess.
Yes.
Yeah, and you might have some question about erythema nodosum causes in female and in such age. What you can give first differential of erythema nodosum? Female, young,
Um,
normal,
not
normal.
pregnancy?
Yeah,
Normal
exactly.
pregnancy.
Yes,
Yes,
yes, exactly.
pregnancy.
Pregnancy.
I did not ask about the sexual history. Yes,
Yeah, I
pregnancy.
didn't ask about female history, yes, but erythema nodosum in female first differential is pregnancy. What else?
Um,
Streptococcal infection.
yes.
Okay, what else?
I think erythema can happen with a lot of
Yes,
diseases.
inflammatory bowel disease.
Yes.
Also with Behcet.
Special disease. Yes, that's right.
Okay, I think this is enough. Sorry, I asked you more, but the topic when we discuss, maybe we'll not repeat it again.
Yes.
So yeah, and you might face it in the exam.
Yes.
Thank you, Dr. Sarah.
Thank you so much.
Yeah, you catch the case, as I said. I think you didn't miss any, I only female history. Apart from this, the onset, course, duration, analysis, association, only awareness of the heartbeat in the system you didn't ask. Apart from this, you ask about chest pain, short of breath or short chest symptoms, the CNS, the weakness, the constipation and hypercalcemia signs and symptoms, mood change, along with the bone pain only remains. You didn't ask bone pain. Apart from this, you discover the hypercalcemia sign. There's polydipsia, polyuria, abdominal pain. Also, you can ask about renal stone. And don't forget also, yeah, by the way, don't forget the management of hypercalcemia. It's one of the complication, and you can mention how to manage it. Especially, it's easy to be managed and easy to be mentioned, like good hydration, diuretics, and you can also offer nephrology in persistent hypercalcemia. Is it? I mean, for dialysis, yes, it can be as indication. Bisphosphonate also can help if normal kidney function. Okay. Apart from this, yeah, the other system review you did, family history, travel history, medication and medical history, and the occupational, the job, smoking, alcohol. For the redness of the eye, you can offer here the driving. Any eye affection in any disease, you can ask about driving. The examination, you started from the chest. Yes, I agree, because a lot of finding you might have in the chest. And you can also offer the pulmonary hypertension signs, myasthenia heave, and due to the fibrosis or complicating the fibrosis. The back for auscultation. The heart, it's not signifying examination in the heart. Only pulse can be AV block. No murmur you might have, unless the restrictive pattern or cardiomyopathy advanced stage, we might have heart failure signs. The redness in the eye as association. Then the erythema nodosum is also to be examined importantly. I think the differential also we mentioned. The asthma as young female with dry cough. The second differential will be interstitial lung disease for any reason, either idiopathic or connective tissue disease. And the third differential, as I mentioned, you can also put, yeah, I think I mentioned the idiopathic pulmonary under the term of interstitial lung disease. You can also add, yeah, I forget what I mentioned earlier. Wait, I will check. So interstitial pulmonary, yes, sarcoidosis, our topic. So the sarcoidosis first, then the asthma, then the interstitial lung disease, either due to connective tissue or idiopathic pulmonary fibrosis. So this is our case. Anyone has any comment, he can write or he can ask or he can send.
Yes, Dr. Basim,
Yes,
excuse me, I have a question. What's the
sure.
definition by layman word for as communication as sarcoidosis?
What the meaning of what?
Of sarcoidosis is still a definition in communication as a layman word.
Okay. As Dr. Sarah said, it's a disease for unknown cause, and it harm or it affects some system in the body, including the breathing system, which is the lung, the lymph nodes, which is responsible for the defense system. It might also affect the eyes. Like this, simply try to be simple. It's not the one talking to you is not a physician or medical field person. So don't explain with major terms. Just be simple in the term. So disease for unknown etiology, and it affects some of the organs, including the lungs, the eye, the heart, and it might be like I mean the finding like granuloma, and the granuloma means some destruction to the tissue by infiltration or deposition. Like this, I didn't prepare it, but you can do like this. You got it? So
Yeah,
be
yeah.
simple. Yeah, be simple, and don't be panic when you have something new to explain. You ask me for the first time, by the way, but I try to be simple and I explain it in my way. It's so easy. Just don't be complicating for explaining. Don't use medical term. Just be and jargon. Use simple things and simple words that you can explain with, and it will be understandable by the surrogate. You got it.
Yes, thank you, thank you.
Most welcome. Some disease, if inherited, you can say runs in family, for example. And runs in family, very simple and explain the all inherited and genetic condition. Just say runs in family, simply. Other disease unknown like fibromyalgia, like our case today, you can say, as I said, disease unknown etiology or unknown cause. Others like defense system or autoimmune. So you will mention the disease attacking the defense system in the body, or the defense system in the body attacking your body parts or body organs, such as, and you can enumerate how many or whatever the organ affected, joint, the lungs, whatever. Okay, so be simple, and as you are talking to your friend, don't do like you are talking to someone in the medical field. You are talking to your friend. You will not give him jargon in the real life, I mean. Okay.
Yes, it is okay. Thank you.
Okay, most welcome. Another comment before moving to the next. Please, Dr. Sarah, write your scenario. I will try to read the comments quickly. Interstitial lung disease, yes, we mentioned. Jared, also, I agree to mention. TB, I think not common to mention, especially if no contact with sick people. However, there is constitutional symptoms, yes. Yeah, I didn't mention also the constitutional symptoms in this patient. It will be positive, loss of weight and fever, and lumps or bumps, yes. So this also the constitutional you should ask about. Asthma, yes, agree, it's common one. Bronchoscopy, of course, bronchoalveolar lavage, non-caseating granuloma, yes. Spirometry, restrictive defect. Eye and hearing involvement also indicate for steroid. Eye, yes. Eye also I can consider as neuro. But it's, yes, it's one of the indication, eye affection or neurosarcoidosis. Bad prognosis in sarcoidosis. What is it, Dr. Rabia? You mean Lofgard's syndrome, right?
No. Lofgren syndrome is a sign of good prognosis. Bad
Uh-huh.
prognosis is slower onset, a disease more than 6 months, a
Uh-huh.
grade 3, grade 4 disease in the chest X-ray, and in
Mm-hmm.
black people, African, Caribbean. So
Yeah.
these are signs of bad prognosis. And
But
absence of
Lofgren,
rhythm nodosum
one
is
of
a
the
bad prognosis.
good prognostic, yes.
Yeah, presence of rhythm nodosum and Lofgren syndrome is good prognosis.
Mhm.
Absence of rhythm nodosum is a bad prognosis.
Yes. Thank you. Good to know and good to add. Thank you. OCP, I don't know what the question for OCP means. You mean the relation? I don't think there is a relation with the OCP.
OCPs for rhythm nodosum. OCPs can cause rhythm
Okay, yeah,
nodosum.
yeah. She's giving the, yes, for differential of erythema. Yes, you're right. I thought for the sarcoidosis. Okay, but you give crackles all over lower and mid zone. I think it's upper lobe fibrosis. Uh, I'm not sure about the apical. I think it's lower. Anyway, if someone has the confirmation, he can confirm for us.
Yes, it's basal. Yes.
Sorry.
Basal. It's basal. Yes, sarcoidosis is most commonly used
Yes.
basal fibrosis.
Okay.
Apical has specific reasons. Most of the
Ankylosing and EEA, extrinsic allergic alveolitis. Yes, this is what I remember also. Apical is ankylosing spondylitis and occupational only extrinsic allergic alveolitis. And the others will be lower, and the medication also lower. Connective tissue all are lower except the ankylosing. This is what I remember also. Do we need to
I
treat
think
hyper? Sorry.
I think sarcoidosis is upper and middle, yes.
sarcoidosis upper دكتور upper sarcoidosis can cause upper lung fibrosis coloworkers
Yes.
clinical alveolitis ankylosing spondylitis histiocytosis all of them can
Yeah.
cause fibrosis. All of them can cause upper lung fibrosis. The lower fibrosis is cryptogenic fibrosis connective tissue disease except
Except ankylosing, yes.
on drug medication and medications.
Drug
As-
also basal. Okay. So let's repeat it again. The upper one, apart from ankylosing, the sarcoidosis and histoplasmosis, right?
Yes, silicosis can cause also
Silicosis.
Antimycosis.
And tuberculosis, of course, yes, TB. Apart from this, all remains are basal, right? Connective tissue, drug-induced, and yeah, other occupational, yes. Okay, thank you for correction. Any other comment, Dr. Rabi? Thank you, Doctor. Dr. Aisha, do we need to treat hypercalcemia in sarcoidosis? Any symptomatic hypercalcemia need to be treated, whatever the reason.
One of
Sorry.
indication of steroid. One of
Steroid
indication of
also,
steroid
yeah.
hypercalcemia.
Yes, this is the other also indication. Sorry, let's repeat it again. Dr. Abdul Minam, no, it's I think Dr. Mahmoud, right? Hypercalcemia, neurosarcoidosis, and I, of course, under the term of neurosarcoidosis, and stage 3 and 4 in the staging of the lung affection, infiltrate and fibrosis. Any comment, other comments? Psoriasis, sarcoidosis in upper and mid zone. Okay, thank you for correction. Dr. Hadil said the lower. So still there are some colleagues are confused like me. So let's repeat it again. It's low, upper and mid zone. Psoriasis and cause upper zone, psoriasis and aspergillosis, I guess. Why psoriasis can cause upper fibrosis? Lofgren, yeah, I mentioned Lofgren in the indication of calcium. Again, so the Lofgren and neurosarcoidosis, hypercalcemia, and stage 3 and 4 in the staging of the lung affection. Okay, I don't know why psoriasis can cause. Yeah, perfect, thank you. Psoriasis can cause fibrosis. Dr. Qadi, or by
Yes,
indirect way.
same ankylosing spondylitis. If
Okay,
it is,
yeah,
same,
as
same,
ankylosing,
yes.
yes. Mhm. But it's not common, Dr. Aisha, I guess. Not
Yes,
common
very rare.
as ankylosing, yes.
And we
Okay.
discussed this before, is the association of interstitial pulmonary
Yes.
fibrosis, the more common association, not complication of psoriasis.
Mhm.
Complication as fibrosis, very rare. But association, it is
Ankylosing.
more common than associated interstitial fibrosis.
Mhm. Okay, as ankylosing, you mean, right?
Yes, if psoriasis is complicated by ankylosing, it can cause
Yes,
apical
right.
fibrosis,
Okay.
but very rare.
Okay. Thank you all. Systemic disease that can cause rarely upper zone fibrosis. Okay. Yeah, it's rare. Yes. Okay. Thank you, Dr. Khan. Doctor. Yeah, she wrote the case here. 35 years old male with patient with shakiness of the hand. Okay, let's prepare. Mr. John, 35, shakiness. Hands. Okay. Okay, ready?
Okay, doctor.
I'll just adjust the timer. Hello there. I'm Dr. Mukhtar, the doctor in the clinic. You must be Mr. John.
Yes, I am the one, doctor.
You are 35 years.
Yes, doctor.
We are here to discuss about your health issue. That's okay for you?
Yes, please, doctor.
Yeah, tell me more, please, about your complaint.
So, doctor, for the past 2 weeks, I have this like shakiness of my hands that it really seems I cannot control it, doctor.
I'm so sorry to hear about that. Can you tell me more? Do you notice it's worsening or the same since started?
Yes, for the past for the past 1 or 2 weeks, it's getting worse, doctor.
And started all of a sudden?
Yes, doctor.
Any previous attack before?
No, this is the first time.
Okay. Do you notice something improve it?
No, even if I try to stop it with my hand, I cannot stop it, doctor.
Did you notice something worse in it?
No.
Okay, another way of question. Did you notice when you move your hand, it worse?
I think yes, when I try to move my hands, but it's there when I am not moving my hand, and also when I move my hand. It's in both, doctor. Yes.
So whenever you're sitting, not thinking, and just resting, there is the shakiness?
Yes, doctor. Yes.
Okay. And is it in both hands?
Yes, doctor. Both hands.
And
I feel
the
that they are
legs?
really.
The legs? Any shakiness in the legs?
I think there is some shakiness, but I noticed it more in my hands, doctor.
Okay. Any sweating in the hand?
No.
Any weakness in the hand?
No, doctor.
Any pins and needles? Sensation,
No.
I mean.
No.
Okay. Apart from this, did you hurt your hand or you have any trauma to your hand recently?
No.
Any trauma to your head or any part in your body?
No.
Okay. Do you notice the alcohol improve it or worse it? Did you notice that?
No, doctor. I think it's not related.
Not related. Okay. So you notice the fingers moving than usual, or the whole arm moving?
As I told you, doctor, yes. My arms, it's my hands, my arms, even my legs are moving, are shaking, but my hands more than other parts of my body. And it's there, as I told you, when I'm not moving. It can be more when I am moving, but it's there also while I'm at rest.
Okay. Did you notice you feel any tummy pain?
Tummy pain. Actually, after you have mentioned it, I think I had some like tummy pain and those motions, like 1 or 2 weeks ago.
Okay. And this tummy pain, it's okay now? You are free now? Or you have any?
Better. I still have some loose motions, but it's getting better, doctor.
Okay, 2 weeks back.
Yes.
Lose motion with the blood, sorry for this question, through the back passage?
No.
Okay, any intolerance to any weather?
No.
Okay. Apart from this, you have any headache?
No.
Any vision affection?
No.
Okay, any hearing affection?
No.
Any unsteadiness?
I think with the shakiness, I feel myself that really am I'm not stable enough to stand up. I think better to sit.
Okay. And anyone notice that your whole body shaking, or only the arms and legs?
Yes, one of my friends, yes, he has noticed that I'm having this. It's really noticeable, Dr. Riyad. He has noticed it.
Did you lose your awareness?
No,
Did you bite your tongue or your lips?
no,
Sorry for this question. Did you lose the control over your water work or back passage?
no.
Is it coming in attacks or continuous
No, doctor, it's there all the time, doctor.
all the time? Okay. Yeah. Are you having any stress in your condition in your life?
It's always stressful, doctor.
Yeah. Did you notice worse with the stress?
Actually, when you mention it, yes, it has. I had some like problems with my mood for the previous few months, and I have been seeing the mood doctor.
And did you take any medication for that?
Yes, he has prescribed for me some medications. It's called lithium.
Okay. Apart from this, any long-lasting disease I should be aware of?
Yes, doctor, I have, I have high blood pressure.
And what you are taking for the blood pressure? High blood pressure?
Yes, I was receiving medication for a long time, for the previous 3-4 years, but recently my GP changed it and gave me something called, I think, hydrochlorothiazide and ramipril.
And are you compliant to the medication?
Yes, doctor.
And the increase of the dose, when exactly? 2 weeks back?
Yeah, I started it on about 3 weeks ago. It started.
Okay. Back to the lithium. Did you increase the dose recently?
No, it's the same, doctor.
Are you compliant to the medication?
Yes, actually, I'm compliant on it because it's really feels let me or it's treating my this mood problem.
And how's your mood now?
It's okay, better than a few months ago.
Okay. You have any allergy to any medication?
No, doctor.
Any surgery before?
No.
Can you repeat for me the other name of the medication, thiazide and?
I think ramipril.
Okay. Okay. Back to your system. Do you have any GI upset now, or if you feel any tummy pain or change of the bowel habit nowadays?
Yes, actually, I have this bad tummy pain and loose motion, but it's getting better, doctor, now.
Okay. Any change of your water work?
No. I think after only this new medication, I had the new blood pressure medication. I noticed I can go to the bathroom more often, but otherwise, no.
Okay. You have any skin rash?
No,
Any joint problem?
no,
Any back pain?
no,
Any short of breath?
no, doctor.
Any chest pain?
No,
Any awareness of your heartbeat?
no.
Okay. Any family history of same problem?
No, doctor.
Okay. And you have partner?
No, doctor.
Sorry for this question. You have any casual relationships?
No.
Okay. Yeah. What's your job?
Actually, doctor, I am a delivery. I work in delivering food and other things.
Are you driving?
Yes, doctor.
Okay. Temporary, Mr. John. It's unsafe to drive nowadays while you have this abnormal shakiness. It might harm you and others. So can you stop temporary driving till we have explaining for what's ongoing?
Okay, doctor.
Okay. You told me, do you drink alcohol?
Yes, doctor. In the weekend?
Are you exceeding the limit of 14 units per week?
No, it's only like in the weekends, doctor.
Okay, do you smoke?
No, doctor.
Okay. May I examine you?
Yes, doctor.
Okay, I will first have a look in his body build. Is he underweight or cachectic?
No.
How's your appetite, Mr. John?
It's okay, doctor.
Any high body temperature?
No.
I will ask for the vital chart of the patient, temperature, blood pressure, and the blood sugar and pulse.
Temperature 36.7, heart rate 80 per minute, blood pressure now 140 over 90.
Okay. Yeah. Any posture drop?
No.
Any signs of dehydration in the hand, skin, dry skin?
Yes.
There is. Okay.
Also.
You extend your hand for me, please, Mr. John.
Yes.
Any fine tremor?
Yes, there is sickness. Yes.
Okay. Any flapping tremors?
No.
Okay. The palm, any palmar erythema, any debilitating contraction,
No.
any sweating?
No.
Okay. The tremors itself kinetic or static?
It's present both with the static and also with the kinetic. It's increasing.
Okay. I will examine tone, power, reflex, tone quickly. Any hypertonia?
No.
The reflexes as well?
It's normal.
The weakness, the power for the weakness?
Yes, normal.
I will ask him to do coordination, clapping the hand, both hand opposite side.
Coordination, right? I heard right.
Yeah, coordination.
Yes, normal.
Okay, can you touch my finger then to the nose?
Yes.
Coordination again.
Yes, I can.
Yes, he can. Okay. Any proximal myopathy
No.
and any weakness in the hand by hand grip?
No.
Okay, in the face, I will examine for nystagmus, any cerebellum friction in nystagmus,
No.
any upward gaze friction.
No.
Okay. Then now to the thyroid, any thyroid swelling, any goiter,
No.
any lymph node in the neck.
Negative.
Okay, I will examine the heart quickly for any displaced apex.
No. It's in the fifth intercostal space in clavicle line.
Okay, any fine basal crackles in the back,
No.
any raised GVP.
No.
Okay, in the can I palpate the kidney in the abdomen only?
Yes.
Is it palatable?
No.
Okay. Mr. John, what's your concern?
What caused this like shakiness that I cannot control, doctor?
Yeah, I appreciate your concern, Mr. John. Actually, you might have condition. This condition is related to the medication you are taking for your mood. It might be in the overdose, and when it's exceeding the normal limit and normal range in your blood, you might present with this shakiness. To confirm that, we have to admit you to run some investigation and blood work and blood tests. And if we find the reason, we will update you about the possible management plan. You have any other concern?
No, doctor. Thank you.
Okay. Till that time, you can stop driving and to try not to hold the sharp object or hot object for your safety.
Okay, doctor.
Okay, you have any other concern?
No, thank you, doctor.
Okay, I missed the leg edema. Any leg edema in the
No lymphedema.
and any plantar, I mean, reflex the legs.
Plantar reflex is okay, flexion. And plantar is going down.
Okay, I'm done.
So, what's your diagnosis?
Yeah, Mr. John, 35 years, gentleman, came with this complaint of shakiness of both hands. It started 2 weeks ago. Along with that, he has a history of also GI upset in the form of diarrhea and abdominal pain. Recently, he has been increased the dose of his hypertension medication by the GP, and he is taking antidepressant, or sorry, by mood stabilizer medication in the form of lithium. And after increase the dose of hypertension medication, we might have increase or toxicity of the lithium in the form of the presentation he presented with. Apart from this, I couldn't find any other data in the history or in the examination. So on top of my differential, I can put lithium toxicity as the tremors is fine here. And due to also the change of his antihypertensive medication. Other differential, I could put essential tremor in such age. Again, is that he has no family history and it's not related to the alcohol. One more differential I can put, yeah, drug induced.
Okay.
A few chromocytoma as well, but again, is that no headache and no other anxiety symptoms or signs.
So how can you investigate this patient?
Yeah, general investigation, blood work up in the form of CBC and liver function tests, coagulation profile, baseline basic investigation. I could add to this some special investigation, kidney function tests. It might be impaired in this patient, either due to hypertension, nephropathy, or any other reason. Also due to the use of ACE inhibitor, it might be affected the kidney function. Specific investigation for the condition, I will send for lithium level to check if it's exceeding the normal limit. Other investigation for the complication or for a possible underlying cause like thyroid function test and other hormones assay. I mean, for the fuchromocytoma, metanephrine in the urine to rule out the fuchromocytoma as well. This is my differential, yes. I will admit this patient because lithium is one of the medication or the drugs has narrow index. I mean, it might be in toxic limit after change of the dose. Patient might have toxicity. Okay.
Okay. What other management you will do?
Yes, management after admission of this patient, I could start with ABCD if there is affection of the circulation, hypertension, or patient has any signs of dehydration. Then I will start to hydrate the patient in the acute state. And sometimes if there is acidosis, we could consider urgent dialysis. This is for the acute attack. For the chronic toxicity, I could call for multidisciplinary team approach, including the nephrologist and specialized nurse. I mean dialysis nurse, for example, and specialized respiratory physiotherapist, GP, and social worker, occupational worker. Education counseling about the condition, and also mood doctor would be also called here to change the lithium to other mood stabilizer or other antidepressant medication. The pharmacological management, as mentioned before, it will be the form of possible dialysis after good hydration if no response to the hydration, and if the limit more than 3, I cannot recall the unit, maybe nanogram per deciliter, I think. Anyway, if more than 3, I guess, yes. And if there is associated kidney failure or kidney diseases or acidosis. Yeah, I think also if recently taken a dose, you can consider activated charcoal. Apart from this, yeah, no specific management. I think hydration, sorry, not hydration, alkalization by sodium bicarb, one of the pharmacological options. Okay, I am done.
Okay, thank you so much. Okay, this is well, Dr. Bassam. This is a case of lithium toxicity. Tremors or shakers of the hand has a lot of differential. Can go from simple physiological causes like anxiety, for example. We should ask about any excess coffee intake or not. In such
Yeah,
cases.
yes, I wrote it, but I didn't ask it. Yes, you're right. It's caffeine.
Caffeine intake. Of course, you have to exclude the CNS causes like Parkinson. And in young age, it can be also going with Parkinson with Wilson disease. Wilson disease has in most cases has positive family history. Also the cerebellar syndrome, the different syndrome, either MS, excess alcohol intake also is important to ask in this case because it's one of the causes of cerebellar syndromes. After the CNS causes can be endocrine causes like hyperthyroidism or of course pheochromocytoma. And it can be also other causes is like chronic renal failure, like also chronic liver failure, chronic kidney disease, chronic liver failure. Also, one of the causes of
respiratory failure, yes, also.
respiratory failure, yeah, of course, yes, respiratory failure also is one of the causes. Then it's the drug induced, like inhalers, salbutamol inhaler. In this case,
Yes.
also, we have to ask about the recreational drug abuse because the recreational drug abuse, yes, some of the recreational drug abuse can lead to shakings of the hand or tremors. Like the history, like you said, like also consideration. We have mentioned the most important things to exclude in the history. Yes, because this is lithium toxicity. Lithium can affect a lot of organs, like the GIT. It can affect the heart. It can affect what else? It can affect, of course, the kidneys, the genitourinary system, and of course the neurological system. So we have to cover most of the. And you have to do a system screen. What else for this patient? Yes, so the most important thing with the discussion of this patient that he has to stop taking lithium. I'm not sure. Some opinions will say that you are the one that you have to give the decision to stop the lithium immediately, without going back to the psychiatrist. Even you don't have to wait for the psychiatrist. Only the psychiatrist will come to give him an alternative. But you have to stop. You have to tell him to stop.
Yes, agree. Yes, you should. First thing to do, stop
Yes.
the offending drug. Yes, I agree.
Yes. Because some other opinions that no, you are not allowed. You have to ask the psychiatrist. But I think better, because you are the one that's responsible now for the patient. You have to check for his safety, and you
So
have
the
to stop.
best way, Dr. Sarah, you can say hold the
Yes, hold
medication.
the lithium. Yes, because he will not be able to take it anyway.
Yeah.
Because he has lithium toxicity. Yes. The cause of the lithium toxicity, most probably the new drugs, the ACE and the hydrochlorothiazide. The diarrhea also can one of the it can
Dehydration.
both. Yeah, the diarrhea can lead to dehydration, lead to the lithium toxicity, and also it can be one of the manifestation of the lithium toxicity, but it's improving. So most probably yes, it is the cause of the lithium toxicity for him. So the most important thing is the CBC, like you said, doctor. CBC, kidney function, liver functions, and you have to do electrolytes. Most important, because the electrolytes also disturbance can lead to lithium toxicity. Kidney function tests can lead to lithium toxicity, or it can be secondary to lithium toxicity. So in both cases, you have to do kidney function tests. Also you have to do the lithium level urgently to check for the level, because according to the level, as you said, I think yes, 3 ml equivalent per liter, he will need urgent hemodialysis. So lithium level is very important, and you have to do ECG also, because of the cardiovascular lithium toxicity. So the management is yes, like you said, of course, non-pharmacological education, counseling, MDT, like psychiatrist. You have to inform the psychiatrist urgently. For the pharmacological, there is no specific, only you have to stop the lithium immediately, and inform the psychiatrist to change it to another medication, as he has mood disturbance, so that he will not go to acute depression, the major depressive disorder or something. If there's any, of course, the hydration is the most important. Also, is the most important part of the management. If there is any electrolyte disturbance, you have to manage. Yes, that's it. You did it good, Dr. Bassam, actually.
Okay, thank you, Dr. Sarah, for the case. Thank you so much. I think, yeah, you covered the topic well also. I remember also the limit or the level of lithium less than 1, the equivalent per deciliter.
Yes.
Yeah,
I think
it has narrow therapeutic index. Yes, narrow therapeutic index. Yeah. Okay. Someone want to add comment, or you?
Yeah, because somebody commented the hypertension. Yes, the hypertension is important also to investigate, because hypertension can be because of the pheochromocytoma, for example, or the hyperthyroidism, or it can be essential hypertension. For this patient, because it has been going for years, it's most probably essential hypertension. It's not related to the new. There is no new high blood pressure with the new symptoms.
I have to ask also about the hypertension onset. Suppose, yes.
Yes, you have to ask it. Because of the
Okay.
pheochromocytoma. The pheochromocytoma will only it will be indicated by the attacks of high blood pressure. It will be, if in such a case, it has to be recent, to say it is pheochromocytoma.
Yeah, but also we have to ask about other signs and symptoms of pheochromocytoma. When it's rolled out, I think hypertension here will be like essential and diagnosed.
Yes, by exclusion.
Yeah, by exclusion. So the headaches, attacks, or sweating and anxiety, all this will go with the pheochromocytoma. But we should roll it out because it might be also one of the differential along with the presence of hypertension. Yeah, thank you, Dr. Qadi. I appreciated this information also. Okay, any other comment?
If can Dr. Sarah tell us again the tremor causes that she said in the first when she started to talk, please?
Yes, the most common cause of tremors, it will be the simple anxiety, for example, the simple patient is taking excessive caffeine intake. So you have to rule out excessive caffeine intake is very important. It can be simple as that the patient is really taking excessive caffeine. Other causes are the CNS causes, like the Parkinsonism, but in such age, it will be the Parkinson with Wilson. So you have to ask about the family history. Also sorry?
Essential tremor, yeah, one of the differential.
Tremors, yes, one of the tremor, simple essential tremor, anxiety, excessive caffeine intake. Then the CNS causes like the Parkinsonism or Parkinson disease. Parkinson plus Parkinson with the Wilson.
Yes.
And the cerebellar syndromes. Cerebellar syndromes will most probably have the nystagmus. It can have other CNS symptoms like the weakness or it will be associated with other CNS symptoms, or it can be with excessive alcohol, right? The patient also you have to ask about excessive alcohol intake. The endocrinal cause is very important to rule out.
Thyroid, yes. Hyperthyroidism.
And the sister pheochromocytoma, the hyperthyroidism and its sister, or the sister pheochromocytoma. Then the drugs, a lot of drugs will cause this, for example, the inhalers, salbutamol, like this case lithium toxicity, for example. The recreational drugs also is important to rule out.
Steroid also can.
Steroids, yes, also steroids can lead to some sickness.
Yeah, Dr. Ahmed had also hypoglycemia. Yes, I agree. So according to the history, you can put a lot of differential. However, try to put the most relevant in your condition. Such age, you could think about the essential inherited Wilson, and I think Parkinson will be down in the list. Elderly age, you can put in the top Parkinsonism, of course. You can also put the 3 organs failure, liver and respiratory, and liver and lung, yes. No cardiac failure, it can't lead to.
Yeah,
So
and kidney failures, the liver and kidney failure.
yeah, liver and kidney failure.
They mentioned Dr. Yes can lead to these ones.
Yeah, kidney, liver, and lung, yes, sorry, not heart. Kidney, liver, and lung, yes. All of them can lead to tremors in old age with comorbidity, if no central cause. If you have central cause like Parkinson, you can put in the top Parkinson and Parkinson plus. If you enumerate the Parkinson plus, you will finish the differential. But you will mention against. For example, for the Lewy body dementia, no dementia, for the supranuclear palsy, you will roll it by the examination. Multisystem atrophy, you will roll it out by Borchardt hypotension. So plus the idiopathic Parkinsonism, you're done with the differential diagnosis. Corticobasal also one of the causes, and the vascular stroke or recurrent stroke. Yeah, I think we covered most of the topic. Thank you, Dr. Sarah, for the case.
Thank you, Dr. Bassam.
Okay, any question before any comment, any question, any comment? No question? So it's clear now. Okay, we will see you tomorrow. If no question, we'll end the session. Thank you all. See you tomorrow. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام.